Welcome, everyone. This is the next episode of Conversations with Coleman. Hello, I'm Rob Coleman, the president of IGCS, the International Gynecologic Cancer Society. And as my final year as president is underway, I wanted to continue, what we started last year is a video messaging opportunity to communicate with the IGCS community in a different manner. These have been informal and fun to do, and we've covered a variety of topics, really in short digestible segments or episodes. Today, I'm absolutely thrilled to have with me Donal Brennan, who's professor of gynecologic oncology at UCD School of Medicine in Ireland, and also to have Sudha Sundar, who's professor of gynecologic cancer at the University of Birmingham, West Midlands, England in the UK. She is the current president of the British Gynecologic Cancer Society, also going to be terminating her term with me in 2022. So thank you both for joining me. First, let's set the stage for the conversation. As you know, almost a year ago, IGCS published a global health equity statement under the direction of the council. I'm so proud of the statement because it conveys strongly IGCS's position and provides really the framework for our programmatic activities. This is something that we read at the beginning of every council meeting. And I think it's great. It's in a way, it's kind of our North Star for when we think about programmatic development. IGCS has grown as a model for global health equity and supports individuals and organizations meaningfully engaged at whatever level in the journey towards social and health equity worldwide. Having said this, Donal, recently you and others brought an opportunity or a challenge, depending on how you look at it, to the IGCS as it relates to ovarian cancer care and the disparity that exists globally. With our newly published statement this year, this could not have fit better into the work that we were doing. So it was such a great opportunity. I wonder if you could tell us a little bit more about the importance of this issue.
Thanks, Robin. Thanks for having me. And I guess came together as a group a number of months ago to discuss a number of different surgical approaches to ovarian cancer. And that's kind of suddenly evolved into a discussion around global disparities and inequalities in ovarian cancer care. And we were very lucky for you and Mary Aiken to allow us to host a large meeting of different people all over the world. And as part of that, Sudha became involved. And of course, Sudha has been a leader of describing inequities and inequalities in ovarian cancer access and care. And I think she's really been hugely important in how we've tried to build this up.
Thank you so much. Sudha, what are your thoughts on this issue? I know you've, as Donal mentioned, you've done quite a bit of work in this area. What are your thoughts?
So thank you for this opportunity, as Donal says, and it's a real pleasure to have this level of support and interest and leadership from the IGCS in this really important space. So I think disparity in ovarian cancer care is an incredibly complex piece of work because it's multi-level. It exists in high-income countries and it exists in low and middle-income countries. For instance, when we looked at the data in England, and this is population-level data, we weren't really pleased to see that in England, in the National Health Service, 1 in 4 women do not receive anti-cancer treatment in stages 2 to 4. Now, this doesn't look good, but in fact, data from the Netherlands is 14 to 20%. Data from the US, which is a bit older, is that about half of the women who receive surgery receive guideline compliant care. So it looks like there's geographical variation in the high quality of standard of care in ovarian cancer that we all aspire to in high income countries. Then when you come to low and middle income countries, there are even bigger complexities because there's so much of data issues that we don't fully understand. We don't understand what's driving it. We don't understand the age distribution of ovarian cancer in low and middle income countries. And certainly in breast cancer, for instance, there's very good data that suggests that breast cancer has more aggressive biological characteristics in the Black African and Black Caribbean populations. And we don't really have that level of data to understand very many fundamental issues in ovarian cancer, such as age, BRCA prevalence, what are the differential diagnoses of a pelvic mass in low and middle income countries. So I think there's disparity and inequity that exists at every level. And I think an organization such as the IGCS, working with its partners, can do a great deal to at least begin to understand these issues and campaign for these things to be addressed in a meaningful fashion.
Oh, so important. I just
sorry, I've given you this huge big blur.
Yeah, no, but it's so true. I mean, this is kind of the point, right? This is, IGCS is really a global society that reaches over 10,000 individuals that are really committed to the care of women, to our patients with gynecologic cancers, and it makes it really well suited. I think that's, Donal, I think as you mentioned, this was an opportunity and to address those disparities that Sudha just mentioned. I mean, what are your thoughts on that with IGCS being maybe as the organizing institution to help us do this?
Yeah, I think it's very important, Robin. I think we're at a crossroads in ovarian cancer care in some ways. In many countries, ovarian cancer care is becoming slightly fractured. There are different people becoming involved in the management of ovarian cancer who may not have had the formal training in gynecological oncology that we have and that we provide and that the IGCS provide, of course, in many different countries. And I think that's very important when we talk about women-centered care, because it's very easy to offer a woman a big operation if you want to do it, but you need to understand what the impact that might have on her adjuvant treatment protocols and things like that.
Right.
And I think that's why it's so important, really, that IGCS take hold of this at a global level, so that we can, protect women in one way from maybe being offered things that are not evidence-based, but also to promote improvement in standards of care and to, I suppose, empower women and also to empower local clinicians to advocate for better care. And I think that's very important.
Yeah, it's great. We have all these tools, but how do we best leverage them? And putting the kind of the complete package together. I think that's great. And you're right. I think that from IGCS having such representation, really it's our mission to get a representation from all over the world, and at least give us an opportunity to leverage that so that we can address this. But Sudha, you've done a lot of work in this area. You published in this area, as you just mentioned. How do we maybe get started? How do we scope and size a project like this? What is kind of data that we might need to obtain to start to put our hands around, our arms around this issue?
I think we've taken the first step in acknowledging this as an issue. Because I think that's the first step to the problem. Because if we think about it, 5 years ago, we wouldn't even be having this conversation. So I think in that sense,
right,
it's been a real positive thing to have the issue of disparities raised. I think the next step would be to convene as many people as possible from across the world, which is, I know, an initiative that you're working on, try and bring as many brains to the piece to understand what barriers there are in the different geographical setups that exist. And then for people to describe their experiences, perhaps looking at data from a quantitative point of view, maybe look at outcomes. I know we've discussed various things, such as cohort studies and surveys, but I think the key thing is to basically get people together to brainstorm around the problem, because this problem isn't just a surgical problem. It's access to chemotherapy, access to medical care, access to diagnostics, as well as understanding how these things play out across the different teams that exist. Because Donald's right, in some parts of the world, it won't be gynae oncologists driving the care. It'll be general surgeons driving the care. But it's really important for us to be working with our surgical colleagues and our general gynae colleagues as well, to make sure that the issues around the right care at the right time happens for patients.
Yep, agreed. Donal, we've had a couple, conversations about this as well. What are some thoughts about how we might tackle a problem like this?
Yeah, I am.
I want the answer, the whole answer right now.
Well, I'm going to come at it from a slightly different way and throw a curveball at you, Rob. But I actually think we can do some very simple things very quickly. And I think one of the easiest things we can do is really determine a shared vocabulary that we will all use to describe different terms in ovarian cancer, because we're all talking a different language, and we're all speaking, in terms that really have been poorly defined. And one of the great ones is debulking. If we need to get rid of words like debulking out of the literature and out of common, I suppose, use with because women don't like it, and it doesn't really define what we do anymore. I think if we can even define a common vocabulary and a common language that we could all use and agree on standard definitions, that would be a real step forward. Because as you and Sudha know, collecting data can be a great undertaking, but sometimes the validity of that data may not be really that good, particularly if we haven't actually defined what we want to collect. I think also, though, as Sudha said, if we can bring as many great minds together to work on this, and I mean that from the point of view of physicians, but also patients. We need to bring patients into this conversation at a very early stage, because I think all of us that have worked in that area will find that bringing patients in at an early stage actually overcomes a lot of the problems that we kind of don't even identify at the start.
Oh boy, that's so true. Yeah, it's one of the things we always start with when we're doing a study like this is getting a data dictionary together, right? A common element of. And I couldn't agree with you more about setting that standard. Well, there's a lot of work ahead of us. I know it's gonna, and you guys, I really appreciate your passion for this, because it's what's going to take to get us through this particular project. But I think it's going to be rewarding in so many ways, and we're so grateful to have dedicated investigators such as yourselves to do this. And I'm super excited to watch how we engage the global community to achieve this. I really feel like the IGCS is kind of the ideal organization to do this, given our global footprint. And I know ultimately this will lead to new opportunities for our patients with ovarian cancer. So this is going to be great. It's definitely a stay tuned for more to come. And we will be working with the IGCS staff to communicate and update the members and our friends along the way. So again, I just want to say thank you to you both. Thank you for your dedication and for your insight, for your passion, as I mentioned, to get this project off the ground. And we're really looking forward to seeing where it takes us. So I'm going to go ahead and close this. Thank you. This has been another episode of Conversations with Coleman. We'll definitely give you some updates as we move along. And again, I want to thank my co-hosts here today for joining us and providing some insights.
Thanks, Rob.
Have a great day.